And you are live.
Thank you. Good afternoon, everyone. This is the Vermont Legislature's Joint Rules Committee. It is Monday, January 10th, and today on our agenda, we have Dr. Sen Noyes joining us from UVM-MC, so we can continue the discussion of how we can best come back into the building to do our work safely and getting a better understanding of what metrics we may use to determine whether to pivot to go remote or not. So with that, I know that Dr. Noyes has a hard stop at 3:30, so I want to make sure everyone has enough time to ask her questions. With that, we have Dr. Noyes state her name for the record, and I think you might have some initial thoughts prepared for us, or should we just start with questions?
I think it's perfectly fine to start with questions. Sen Noyes, infectious disease attending, University of Vermont Medical Center.
Great, thank you so much for being here with us. So, as you know, we are just working really hard to figure out what metrics to use to determine whether we should pivot to remote or not. And I understand that you've been proactive in figuring out what that looks like for UVM-MC as well. So I would love to hear your initial thoughts on how you approached it at the hospital, and if you have ideas for how we can approach it at the State House.
Yeah, I mean, I think for us, with the delivery of healthcare, most of that can't effectively happen sort of, remotely. And so the majority of our patient visits are happening in person. There are some services within the hospital that can be performed remotely. So many of those people have that option when they don't have to come in and actually sort of, perform their duties in person. It's a little bit muddled because that process was happening where, it was sort of reevaluation of work and where it needs to happen. That was happening sort of as COVID began. But, our sort of in-person care is really, reverted, or our healthcare is really reverted back to in-person at this point. We still have the option for telehealth when it's appropriate, because some people actually prefer that, but most of our visits are happening in person.
So Dr. Noyes, are there metrics that you would advise us to use in putting together a formula for what would act as a pivot to go remote?
I think that the community transmission rates are probably going to be the most informative. That's something that we factor in and we look at every day. So the, number of positive cases, the rolling 7-day average, all that is pretty accessible. In terms of what should the threshold be in terms of, when to pivot to remote, I think it depends on again, the level of care, or the sort of level of in-person need that people have to get the business done. Again, for us, I think it's a little bit different. Most of the functions we perform really need to be in person. So it's not really an option. The other piece that may be helpful is to get a sense, and I don't know if you have the ability to do this, but to get a sense as to, if you have a number of people who are absent because of symptoms themselves, that may be a good trigger as well. Because I think, one of the big strategies that we've used here at the hospital is, if you're having symptoms, stay home. That really has been a big shift for us. And to have a remote option for those folks who are mildly symptomatic awaiting a test who can still perform their duties, but again, be remote so that they're not potentially exposing others. Again, we don't just have COVID wildly transmitted in the community, but influenza, metapneumovirus, like a million other respiratory viruses are also circulating. And so, and you can't tell the difference symptom-wise from COVID. So really testing is the only way to do that. So I would say community transmission and absences in your own, group probably will help determine, is there a proportion that is right? I think if absences are rising rapidly, sometimes it's not a rate, it's actually the rate of rise. So if you're noticing significant absences increasing one day to the next, that may be a good trigger.
Okay. I'll open it up for other questions. I'll let people get situated. Yes, Senator Clarkson.
Thank you, Cindy. Thank you very much for making time for us. I mean, we're currently remote, the State House is, and so we're trying to determine when it's safe to resume our business, because we have a responsibility, obviously, to keep the public, the legislators, the staff, everybody in the State House as healthy and safe as we can. I'm just curious. So we've reached out to various academic institutions that have standards for these kinds of things as well, and that are making the same kinds of decisions. And everybody's a little different, although everybody interprets the things you've talked about in their own way and with their own context. One of the questions I have for you is, does the hospital have a uniform standard for entry? Is everyone on the same does everyone enter the facility with the same expectation? Does everyone have to be vaccinated or, masked? I mean, do you have a uniform standard for entry to the hospital?
And so that's a great question. So our staff, we were moving towards mandatory vaccination, as you all know, and then there was a hold on the sort of ruling, and so we held on that as well. The majority of our staff are vaccinated. We are not restricting unvaccinated visitors, and so visitors who are coming to visit their loved ones. The most important thing strategies we've used, there are two. The first is screening on entry. And so all visitors coming to the facility are screened on entry. Do they have any symptoms? Have they had a COVID positive test in the last 10 days? And if they answer positively to those questions, if they're coming to visit a loved one, we ask them actually to return another time and to contact their healthcare providers. If it's a patient coming to see me because I need to see them because they have a fever, they're identified as having a symptom. Because again, we see a lot of people who don't have COVID as well. And so they're roomed quickly once they get to our clinic. And so we really have sort of visitor intervention right as you walk into the multiple doorways. We funnel people to 2 different entrances, and so that they really have to be screened before they go anywhere within the hospital. And then the other piece is masking is required for everyone who comes into the hospital, with the exception of toddlers and infants who can't mask. And so those are our main strategies at this point.
Dr. Noyes, do you have a recommendation on the type of mask used? Do you have a certain level that you use? I'm just curious about that, and then we'll go to Representative McCoy.
Right. So some cloth masks are absolutely adequate. Others are completely inadequate. And it's impossible for the person who's greeting the, sort of visitors at the door to know the difference. And so we are sort of providing these procedure masks in order to sort of ensure that people have a standard that we're achieving. I mean, even though these look ridiculously flimsy, there are 2 filtration layers and a fluid repellent layer. And so that might be something to consider, offering all of the, folks who are coming to work and the visitors coming into the State House, procedure masks, to be sure that, people aren't walking in with gaiters, which really don't do anything. Masking is really important.
So, Jill, can I just do a follow-up on that? How would you rate the procedural masks, Cindy, versus a KN95?
I would say that from our contact tracing, and this is really the sort of experiential information that we have, the KN95s have a higher rate of filtration, but and so, it's certainly reasonable to use those. I have not used those. I don't use an N95 unless I'm seeing a COVID positive patient, a fit tested N95. But everyone in the hospital is wearing these procedure masks. And I think source containment is incredibly important. And we've been very successful because we contact trace everyone within our walls. We've been really successful at drastically mitigating spread within our walls with consistent use of masking.
Mm-hmm. Senator Clarkson, did you have any other follow-ups there?
No, that it just, I assume that when you talk about the visitor screening, that the contact tracing is a piece of that you collect everybody's information on the way in.
We do.
Okay.
Thanks.
Thank you. Representative McCoy.
Thank you. Thank you, Dr. Noyes, for being here. Can you just expound on the 2 different entrances of entry to the hospital? Is that for all visitors and employees, or do employees enter a different entrance?
Right. There are a few extra doors that are locked. We have to use our badges to scan ourselves in. Okay. We used to have everyone, including all employees, all visitors, screened, but the employees who've had repeated screening are trained. We've sort of done competency work, so we don't screen them actively every day. They are screening themselves, and if the employees develop symptoms, our sort of advice to them is stay home, let your manager know you're going to be out, call employee health, and we'll arrange for testing. And that's generally what we do. But all the entrances are locked and they have to badge in if they're going to, sort of enter in those other places.
Okay. So do you have one of those temperature, you walk into a door and like it's a X-ray screen that says you're okay to pass because you don't have, okay.
No, we've found that is incredibly unreliable, and a lot of people with COVID don't have fever. Okay. Even when they're hospitalized, it's very transient. It's actually not a very sensitive marker, and the most recent literature suggests that it's probably not worth the effort because we're not really capturing people in a sensitive manner.
Okay, and then you had mentioned the number of cases increasing when the speaker was asking about metrics. Would you consider hospitalization rates and ICU rates, which seem to remain stagnant, gone up a little bit, but where cases increase, the hospitalization and ICU rates seem to remain pretty level?
Right. I mean, that is a really complicated question. I think what we're seeing is that I mean, I was on call all last week and people would come in with life-threatening infection and COVID. And so I think we're starting to see that decoupling that, sort of some national experts are suggesting. Having said that, we're not counting people who are coming in for their hip fracture and
Right.
COVID separately. So it's probably not the most accurate reflection. The other piece is that people who have severe COVID may be hospitalized for weeks, and that may be due for a number of reasons. Number one, they have really severe underlying lung injury, and that they're on a ventilator. It's just going to take time. Or they're really deconditioned and no nursing home will take them to be able to start that rehab process. And so those numbers are very nuanced in terms of what they truly represent. And they may be, and maybe stagnant is actually better because we're not consistently adding lots of numbers. It may very well be those same few people stay in the system because discharge isn't an option, or they're really sick and their recovery is going to take a long time.
Okay.
So I don't know how informative that would be.
Okay. And pardon me, but deconditioned?
Yes, I'm sorry. Thank you for, I apologize if I use any words that don't make any sense. Please let me know. Regardless of infection, if somebody is admitted in the hospital and they need ICU level of care for weeks, they're not moving, they lose muscle mass, they become really weak globally. And so they will need a level of recovery that addresses, their general weakness and inability to tolerate, walking into the bathroom or walking up the stairs. So that's what deconditioning is.
Okay. Thank you very much. Appreciate it.
Yeah, go ahead, Senator Brock.
We had a gentleman, a physician from UVN come and visit with us 2 or 3 weeks ago. And we were talking about masking and the effect of masking as a means to prevent COVID transmissions. And one of the things that he mentioned, of course, was the amount of time that we might be exposed to someone who is masked is a factor in how effective that masking is. As you talk about the committees that we have, typically in the Senate, we may be in the same room with effectively the same small group of senators for 3 hours a day, and we go twice a day. Is that a risk, or is that something masked that folks should be comfortable with?
I think always there is a consideration for all of these factors. I think the risk of transmission is dramatically reduced if everyone is masked. When the wearer is masked, and if they were to have, asymptomatic COVID and were shedding and didn't know, it contains people's sort of aerosols within that area. The other people in the room are protected with their own masks because that protects them from the aerosols that may escape from that asymptomatic, newly positive person. We know masks aren't 100%, but they drastically reduce the risk of transmission. When people have mask to mask exposures, and again, we have healthcare workers who are in the same room with people for hours on end during the day. We've not had dramatic transmission with our healthcare workers getting infected at work when people are wearing the proper personal protective equipment. I think if you had a cloth mask that became saturated, because if you're talking like, there's spittle sort of getting trapped by the masks. If things start to get wet, they don't filter as well. And so, if there's any contamination or sort of moisture on the mask, it's not going to work as well. And so, maybe it may be worth thinking about sort of changing the mask if, if you've sneezed or coughed or there's, actual sort of moisture on the inside of the mask. And that's what we would do here. But again, we have people who are in rooms with folks for hours, cumulatively through the day. And we've not had transmission that, we can prove has happened in the hospital from patients to staff as a result of people's PPE use.
If you were designing for us the solution to the problem that we have, how would you advise us to make a decision as to whether or not we remain remote for a period of time or whether or not we resume in session, and how we make the decision between the two? What would you suggest?
I know, and I apologize. I should, but I don't know all of your processes, and I know that there are lots of little meeting rooms, and the, the State House is beautiful, but elderly, obviously. And so, I probably am a little bit ignorant in terms of, all your processes and needs, but our hospital, there are parts of our hospital that are pretty old as well, and we have to deal with, aging infrastructure too. I think behaviors have been most important. And so when we can't change the HVAC and we can't, sort of modify other sort of infrastructure, I think behaviors have been important. So really instilling in people, if they develop even mild symptoms, like people who are vaccinated and boosted, when we've seen breakthrough infections, including with the Omicron, but also with Delta, we've seen people develop symptoms. And so if people develop symptoms, even mild symptoms, they should stay home. And that's what I would encourage people. And so that's one piece. And masks should be absolutely mandatory, and drastically limiting unmasked kind of times during the day, like eating and drinking. And we've had, challenges here. I mean, I'm an ID doctor. Usually eating and drinking isn't a big risk for infectious disease, but with COVID, it really is. So trying to sort of space people out has been really important. We've really tried to emphasize that with people. And so if we can't change the structure, I think trying to really ensure that people are following those behaviors consistently is really important. And that's what we've designed, and it seems to have been effective up until now.
Thank you.
Senator Ballant and then Representative McCoy. No? Okay, Representative McCoy.
Thank you. So just getting back to the masks, as Senator Brock had said, he might be in a committee for 3 hours in the morning and then 3 hours in the afternoon. Would you suggest just like a mask change out in between? A lot of us speak a lot of us talk a lot in committees, and, may not seem that the mask gets moist, but it may. So if we have a policy of changing out a mask twice a day or something, Yeah,
it would be arbitrary.
Okay.
And I can't point you to a specific, guidance that we would use. We basically say, if it becomes soiled or wet, change your mask.
Okay.
And it may very well just be having those masks readily available everywhere, so people can do that on their own. You can tell when they get wet.
Yeah. Okay. Thank you.
Representative Long.
Thank you. And thank you for coming, Dr. Noyes. These questions about masks have prompted me to ask a question that I've been hearing from caucus members who tell me, or legislators who tell me, they spend a lot of time in dry rooms in the State House, and they do what you just did, which is drink frequently in their committee rooms, and are concerned about removing the mask, even for just a few minutes, to drink some water. How much more vulnerable are people who are closed into a close committee room for several hours, taking that mask off, even just for a couple of times, to drink water or to eat a little something or do whatever in a committee room? Does that make them more vulnerable?
I think anytime you're unmasked, there's higher risk for exposure. And so I really try and limit sort of eating and drinking. And it may be worth sort of scheduling a break in between so people can separate and then do their hydration at that point.
Mhm.
If you can build the structure into the day, that might be really helpful. Because that I think it's hard to quantify, the risk. And so I think if you have asymptomatic people and you need to sort of take a quick drink of water, it's fine. And it's easy to do. Like, I mean, I'm in my office by myself, so I don't have my mask on, but it's pretty easy to pull your mask down and, take a swig. I think that's very low risk. But I think if you want to be uber conservative, I think it would be reasonable to, if you can structure it in your day to have little breaks where people can separate, I think that might be a really good thing to do.
Thank you. That's helpful.
Dr. Noyes, right now we currently have as our policy for staff and members that they would either have to show proof of vaccination or get tested once a week, a PCR test. And should we update that policy to include boosters at this point? There's been a lot of questions about boosters.
Right. It's very timely, in terms of the questions around, what does fully vaccinated mean? And, I've actually sort of changed my terminology. So I call it optimally vaccinated, because it may change in 2 weeks. We are doing the exact same thing that you all are doing. I mean, obviously the Department of Human Health and Services and CMS has mandated, vaccination for all healthcare employees, and that has been our trend, and we're close. But when they sort of put a halt on it, so did we. And so in the interim, we are continuing with our plan of weekly testing for folks who are not vaccinated. Currently, our definition of vaccinated is the 2-dose primary series.
Mm-hmm.
If healthcare workers are immune compromised, we kind of assume, and we have a list, we kind of assume they won't make the usual antibody or protection response to the vaccine. So we would, if they had an exposure, we would consider them unvaccinated. Just for the purposes of, sort of work restriction, et cetera. The booster, we've seen, the boosters are great, and we strongly encourage it. But we've seen people who receive their primary dose of vaccine, so two sort of mRNA doses with no booster who have been protected from, infection. And we've also seen boosted people who've developed infection. So it's a little unclear. And, I think we're probably going to wait for the federal guidance in terms of, are they going to change what the meaning of, sort of a primary series is. Honestly, over time, I suspect we will need boosts periodically.
Thank you. And one other question I got was around saliva testing as a non-invasive alternative to the nasal swab. What are your thoughts on that? And is that an accurate enough test for this latest variant?
And are you talking about antigen or PCR testing?
PCR.
Yeah, and so we've had the request from some of our employees in the fall. And the bottom line is that it's probably pretty close from, a test performance standard, but there's no lab in Vermont that is validated to carry this testing out. And actually, there are very few commercial labs who will do this. And so I think we might have found one candidate lab in Connecticut. And so, and the anterior nares swab, I don't know if any of you have been swabbed, but it's really, I mean, my kids do their own self-collection for their school testing. It's really, I wouldn't call it invasive. I think it's very minor.
And my understanding is that kind of test has been shifting some, and I'm just curious if you have identified a lab. What is that process? Is it at swabbing in the mouth, or is it, doesn't sound very formal. It's spitting into something? Is it, I'm just curious what that process is like.
No, we didn't pursue it.
Okay.
And so there are saliva tests for some of our researchers do genetic testing with using saliva. So there are certainly lots of salivary tests that can be performed. We didn't pursue it from a COVID standpoint. And I think the anterior nares, which is just the swabbing in the front of the nose, is, the test performance is very good. And so, I think people are trying to move away from the nasopharyngeal swabs that go all the way in the back,
Right.
because, the testing characteristics are good.
And with that, so that was for PCR. What about the other one?
The antigen testing?
Yeah. Mm-hmm.
I have a lot of thoughts about antigen testing. I'm not sure that any of you want to hear them. Generally speaking, I think that they have their certain purposes, but there are limitations as well. And so in a person has symptoms and has an exposure, and they have a rapid antigen test that's positive, the predictive characteristics of that test are actually quite good. If you have an asymptomatic person doing that test, it's not nearly as good. And so people can have false positives, and they can also have false negatives. And it takes a lot of time and effort to be able to sort those things out. And usually the PCR is the better test in terms of sensitivity and specificity. And the other piece is that all of the people performing these antigen tests at home or at school, they're not laboratorians. And so I'm sure you all remember the outbreak in Manchester. That was related to sort of non-laboratorians performing these tests, and they're notorious for pseudo outbreaks. And the reason being is that we contaminate our world is sort of, we use our hands to explore our world. We contaminate the sort of, test collection equipment, and, we can get a positive and not be positive at all. So I think there are certain niche uses for those tests. And it makes me nervous that everyone is doing them, because I don't know that they're all able to interpret the diagnostic sort of information that they're giving.
Okay, thank you. I'll pause and see if any other members have questions. I have a couple more, but I don't want to make sure everyone
Madam
has
Speaker, you're on a roll.
So we briefly mentioned the cafeteria scene. And this is frankly, my biggest concern is just how to manage the cafeteria. Obviously, we are thinking of ways that we can stagger committee time so that in other meetings, so we don't have a lot of people in the same space, creating other space for people to go and eat at. But even with that, I would anticipate that people would be gathering and eating in the cafeteria. And I just, any thoughts on how to best, besides moving the tables and chairs as far apart as possible, doing all these things, is there any other advice that you would have for us?
That's actually exactly what we've done is, we've really tried to educate people that, this is where people run into trouble. We are humans, and we love to congregate, and it makes sense. And that's some of the best sort of, collaboration happens informally in those situations. The other piece that I think we've run into, and again, I'm only sharing the stuff we've learned from contact tracing, because that's really where we've seen staff to staff transmission is in the break rooms.
Yeah.
And so, and just because, we go to work together every day and you look fine and you're healthy doesn't mean that coming to work tomorrow, you may not sort of be developing COVID. And so I think that we have to really just be as structured as we can. We physically move the tables apart. We've only put one, chair at one table as best we can. We try and discourage people from eating together. People will continue to congregate. I just think that they need to know that, there is risk there, even if people look well. The other thing is we've opened up our big conference rooms to allow for that is another place for people to go and eat. Mm-hmm. I think staggering your committee times and trying to utilize the structure of your day, like designing the structure of the day, I think is really important. And that may really help a lot, in terms of if people can, stagger by even 20 minutes, I think that may make a huge difference. But I don't have any, I wish I had better solutions, but we haven't come up with any.
No, that's helpful. It's just reassuring that we're taking those, and I think we can do more around spacing out the tables and chairs for sure. Representative Long.
Thanks. That sort of prompted an additional question that I remembered someone asked me. We don't only congregate together for our meals, and I totally understand how we could help mitigate some of the risk there, but we also live together in homes. We rent homes together, and we are so busy that we often go out to eat at night because we rarely have time to cook for ourselves. And so it seems to me that makes our situation a bit of a higher risk. And is there any recommendations that you have that we could do to mitigate that besides just the obvious try not to be around other people? I mean, and then of course, adding on to that is that we all go home to our separate corners of the state every week. We come and go every week.
Right. Takeout has been a strategy for when people, and we can't eat outdoors now, it's so cold. But I think, if, takeout and, I've gotten really good at all those apps for those, and the restaurants are really good as well. So I think that would be one strategy I would encourage people. If you have your own little household unit in Montpelier, trying to reduce exposures in other places probably makes sense, and then I think, traveling back to family, then, your family are probably exposed in their community. I mean, it is literally everywhere. So I'm not sure that geography really is limiting us in any way at this point. And so I think everyone has widespread community transmission in their own home communities. And it really is about sort of just trying to reduce risk of exposure. So I feel totally comfortable going to, the grocery store because I'm masked and it's pretty transient, but I haven't gone to the gym for a while. And I mask at the gym. I'm like the only one, but now I'm not even going to do that because it's just, I have to be able to come and take care of patients. So really, I think people are the best judges of their own sort of where they can take risk. And I think just maybe having those conversations, because we've had them as healthcare workers, like my kids go to school, so I don't go to the movies. You know what I mean? Like you balance your risk and you take measured risks based on sort of, what your needs are and what the needs of your members and your family are. I know it's not a very good answer, but I think that probably makes sense to have those conversations with your housemates, because I think that they're really important. And they're not always easy conversations, but I think it's good to have that touch point. And if people are staying home.
Thank you. That's very helpful.
Senator Clarkson.
Well, Cindy, you've touched on what we call in our family our risk budget. We're very familiar in the State House with financial budgets, but we're now having to acquaint ourselves with risk budgets. And that is really what we're trying to determine is what is our risk budget for the State House and for our employees, for our public, for our members. And that is, that's it. And so we're building that budget right now, our risk budget. And that's where your advice and counsel is going to be very helpful for us as we build that budget.
And I think that that's very important. I mean, again, and not to belabor this, but you know, we all come to the hospital every day. I work with patients. Some of them have COVID. Many of them don't have COVID. I feel like our PPE strategies have been really effective. And so I feel comfortable going home to my family, and I haven't had, you know, sort of, I haven't had concerns about that, you know, especially once we started seeing the data, our local data from our contact tracing. And I think having layers of risk mitigation is far better than relying on one strategy. So that's why symptom screening is important, and being sure people have adequate access to testing. So if one of your members is symptomatic, mildly symptomatic, if that person can be tested in a, you know, sort of a really sort of a quick turnaround, that can be really informative. And then, you know, I think the PPE and really sort of being vigilant about masking, I think has saved us.
Senator, do you have a follow-up, or are you good, Allison?
No, I'm just trying to equate it into our budget.
Okay, got it.
Vigilant masking plus
Right.
testing plus symptom screening equals a healthy state, you know, equal and plus fully vaccinated equals a healthy state house.
Senator Ballin, go ahead.
Doctor, thank you so much for your time. Appreciate it. Question I have is, when we look at our expectations to when this surge is going to be, you know, really moving through the state based on the experience in other countries and other states, what is our best estimate as to when we will be, you know, over the worst part of the surge? And really, I'm not asking you to sort of, you know, be a fortune teller into the future, but based on the modeling, what are we anticipating?
I have really talked to, you know, other colleagues in infectious disease and our infection prevention team. And I think the next 2 weeks are going to be really, you know, sort of the biggest part of our surge. And my hope is that over the course of the following 2 weeks after that, we're starting to see numbers decrease. I wouldn't be surprised if we saw a rise in numbers this week. I mean, it's hard to look at the numbers from last week and think they could go higher, but I suspect they will. But I hope that in sort of at the end of the next sort of 3 to 4 weeks that we start seeing some plateauing and then some reduction in cases. You know, and as you know, every model is wrong. It's just how wrong is it, right? And the other thing that I think is a kind of a wild card this year is, and this is weird because I've been following flu for years, but in early November we had a big spike in flu and influenza, and I don't know how that's going to factor in this year, and so that makes it a little bit less predictable in terms of, you know, we're dealing with, you know, incredible amounts of COVID right now, but what other sort of respiratory viruses will be looming, because we should be in the midst of flu season as well in the next month.
Thank you.
Other questions for Dr. Noyes? All right. I have exhausted my list, so I'm giving members one last. Yes, Senator Brock, is that your hand?
Well, the only question that I would have is there anyone else in public health and infectious diseases, anyone else that you would suggest that we consult with to get a broader opinion or a slightly different opinion or an opinion from a somewhat different perspective?
I mean, Dr. Levine, I think, is always a good resource. You know, the team that I work with here, none of them really do infection prevention or public health. They, you know, we have a specialist who works in HIV. I mean, she's not going to be able to really probably offer additional COVID information. You know, off the top of my head, I'm not coming up with a name, but I could certainly send one to you if something arises.
Thank you very much.
Mm-hmm.
All right. Any further questions for the doctor? Dr. Noyes, thank you so much. We really appreciate your time. This was very, very helpful. Thank you.
Well, thank you for all your service and good luck. And I think mask up and we'll sort of weather the storm in the next month for sure.
Thank you. Take care. All right, members. So what I'm thinking for next steps is we get another meeting on the books and let folks process what they heard today. And I'll do some individual check-ins with members tomorrow to see if you have any further questions or anything like that. What I heard today made me think that we should just look at the mask policy again to see if we should further clarify like a standard. So that's something to think about. And we can bring in our Sergeant at Arms and the Chief if there are any other questions. I know that we do have a process in place for getting people's names for contact tracing. I saw that came up today. I know we have that process in place. I think we could do more to space out the cafeteria as well. So think about that. We should also think about the conversation around allowing members to participate. We've talked about participating remotely. If we want to talk about voting there, and what else? And I think we could do some more work around timing of committees coming in and out as well, just like that structure and floor. Are there, yeah, go ahead, Senator Brock.
Was Dr. Levine invited to testify before us?
I don't think so. I am looking around. No, I do not think so.
I mean, since Dr. Levine is in effect the senior public health officer in Vermont, I would think that it would be important to hear from him.
We can add him for see if he's available on Wednesday. I'm a little concerned about our turnaround time, but we could see if he's available on Wednesday. Senator Clark.
He's willing. I think if he's willing to come, I think that would be helpful.
Mm-hmm. Senator Clarkson, go ahead.
Thanks, Jill. I think the other thing that Cindy identified was really a rigorous symptom screening with people coming in. So no matter when we decide to come back, I think what I heard also the takeaway, what I'm looking at in all the states and the countries that have been looking at the Omicron in particular, is that it you know, it's going to take us another 2-3 weeks to peak. And then we'll come out and begin to plateau. And because we're so highly vaccinated, it will plateau before it collapses. But I think, you know, when we come back, we're going to need to have symptom screening that's much more robust than I think we have planned. And I think we really need to consider better masks, not just asking for them as available, but that being provided to everybody. One of the gifts of the federal government has been giving us money. So it's not like we don't have the money for that. And so I think those are my 2 additional takeaways is better masks and a much more vigilant, you know, much more robust screening, symptom screening.
Yep. Since the house was back and we did have visitors, and I'm wondering if it would be helpful for people to get a quick update from the Sergeant at Arms or the chief about how that process went. We could do
Yes.
that.
That would be good. But also, I'd like an update. I mean, she asked us a question that I can't answer, which is how healthy is the legislature? How many cases came, did any cases come out of you gathering on Tuesday? I don't know how healthy. I think the Senate is pretty healthy because I don't think we have a case at the moment in the Senate, but I don't know about the rest of the legislature or the staff.
Yeah. Representative McCoy, did you have a question, or are you okay with us getting an update? Oh, you're muted. You're muted.
My question kind of piggybacked on Senator Clarkson's. I believe Dr. Noyes said something about self-screening for employees. I think she's talking about that rigorous screening was for people coming in to the hospital. But we ourselves would self-screen daily, said, do I have any symptoms? Or maybe we have a checklist. We don't go through a screening process every day. We would self-screen prior to arriving at the State House. That's what I took away from her testimony.
Mhm.
I didn't hear is the staff exempt? I mean, I know they come in a separate door and have a badge, but I'm not sure I heard her. Maybe we could just ask her that. Maybe we could do a follow-up question and ask her that.
I thought she said self-screen for staff.
I thought that's what I heard too. And
That's what I heard.
maybe the chief knows as well. I saw his hand. So with that, why don't we open it up and welcome our Sergeant at Arms and our chief to give an update. And you've been hearing this conversation, so appreciate you being here with us.
Yep. Thank you, Madam Chair. Janet Miller, Sergeant at Arms. During the last time that the House was here, we did have someone posted at the door for the public, and we did.
Oh, uh-oh. Oh.
When
She's
they came in.
Senator Mazza's room, and she's,
Oh, did I freeze up?
You did.
Yes.
Sorry.
Oh,
We heard
sorry.
none of that.
I'm sorry. I'm a little unstable, but it's just my internet. Sorry about that. I'll try one more time and then I'll let Matt do it if I don't. So we did ask some folks if, if you would like to please, if you're not vaccinated, would you consider taking an antigen test? And no one took us up on it. And so that was the piece that we did the other day.
But could you tell us, was there screening questions? Do you have symptoms?
We did not
Okay.
ask it. We just had it posted.
Okay.
Mhm. And we,
Oh, boy.
I think you're frozen again, Janet.
She is.
I think what Matthew Romiak, Capitol Police Chief, I think what Janet was about to say was that we did have the N95 masks and we offered those to staff if they wanted them.
Mhm.
Right.
On their way in.
and we did have the temperature screeners there, and I know the doctor doesn't seem like she's in favor of that, which totally respect that. We had put them in as just another tool that maybe people might think twice if they weren't feeling good, that perhaps that might trigger something, and maybe I shouldn't go today because I don't quite feel up to myself.
Okay.
But-
Senator Clarkson?
But Janet, when you walk in, you don't, you just walk right by those things. I mean, making people stop and stand and learn how to read the machine. I mean, that would be an additional piece of it. I mean, when I've been in the State House in the last couple of weeks, I just cruise by that thing. Aren't you supposed to stop and let it register you? And I don't even know if it exploded and I was a big positive guess. I wouldn't even know that because I'd already been 10 feet beyond it. So unless it was a big explosion.
Go.
I don't really know what their value is. I mean, somebody
Senator
taking
Clarkson, if you
stop
want
that.
to, if you want to see what it looks like when it goes off, bring a nice steaming cup of coffee in with you next time.
Okay. Oh, I
when they
remember
go
that.
off. And in all seriousness, though, those are designed to screen multiple people at a time, as big groups, high volume. We specifically went in that direction. And if they do go off, all the Capitol Police officers and sergeants at arms get an alert with a snapshot of who it was, so that we can try to go track you down. We have yet to see a actual alert based off of anyone with a fever, though. We did take them down for a good period of time last year, but I know it's the same units that the Burlington Airport put in, and it took them, I think, 7,000 or 8,000 people before they got the first alert.
Mhm.
You were speaking about entrances into the hospital, and I can't speak directly about UVM, but since CVMC is a UVM network facility, I think they're undergoing the same processes for employee entrances. And when I go in through the employee door up there, there are the very clear screening questions posted, and we modeled our signs after theirs, quite frankly. Said, by going past here, you're telling us that you don't have any of these symptoms. And then you pass by a similar but substantially more expensive temperature screening machine up there. So I don't know if that helps or not.
Does. Thank you. Do members have any questions for our Sergeant at Arms or Capitol Police Chief? Go ahead.
One thing, Madam Chair, in our cafeteria, as you know, we haven't distanced.
Oh, boy. Do you know what she was going to say, Chief?
Please again.
I'm going to try to read her mind.
Cafeteria.
I think she was going to say that we've lowered the overall density of the room, but we haven't really distanced like individual chairs from each other. But the overall density, we took probably half of the seats out of there, Janet.
Yep.
I think.
Yep. Okay. All right. I'm not seeing any hands. So with that, go ahead, Senator Clarkson.
Just quickly, Janet and Matt, how quickly could, I know you have N95 masks available, people ask for them, but to get the volume when we reopen, how are you able to get those fairly quickly if we were going to offer those instead of the flimsier simple masks?
Well, Senator, if you recall what Dr. Noyes said, they're in those procedure masks just like we have available at the doors already. And we do have about 20,000 of those on hand.
Of the surgical procedure mask?
The procedure mask, yes, ma'am. And I did a quick back of the envelope calculation because I expected this to come up. And for 15 weeks of the legislative session, 2 masks a person, we're using 300 as a round number for members and staff. It's not quite that, but it's close enough. We're looking at probably 45,000 masks, which I think we can get that. I don't want to commit to being able to get that, but I think we can get that. I could probably have an answer for you by Wednesday.
Yeah, we have time for 15 weeks.
Well, I mean, we're in week 2. And if we call it an 18-week session, we're in week 2 now. So
if you could find that out, that would be really helpful. Thank you, Chief. All right. Senator Mazza, did you have your hand up?
I just have one concern. We haven't talked much about it. Is the committee rooms the size they are to have folks in to testify? I mean, at least now they have the opportunity to go online and testify. And last week I had quite a few folks in my committee that way, but the size of the room is going to be very difficult to how many people you allow in. If a committee alone takes up 5 or 6 or 7 members with the staff, how do we handle that and still be kind of comfortable? We're talking about spacing in the cafeteria, which I understand we're eating there, but just the committee room itself, it's going to be pretty crowded. That's my concern. I don't know how we're going to do that.
That's right. It is harder to socially distance in the committee rooms. However, if everyone's wearing the proper mask and making sure that they're wearing it correctly, in addition to, we've lowered, the Sergeant at Arms has gone through and labeled capacity limits in the rooms to be adjusted for socially distanced around who's in the room. So there are several measures that we have put in place, but it's a fair concern.
Thank you.
We hope people are taking up the option to testify remotely. All right, any other questions for the Sergeant at Arms or the Chief or General before we adjourn? All right, so be on the lookout for a meeting invite. We'll find a time on Wednesday, and then I'll be following up with you to get your thoughts and feedback for that meeting. So with that, thank you everyone for being here today. Oh, Senator Clarkson, do you have a question? You're saying goodbye. Great. All right. Well, with that, we are adjourned. Thank you, everyone. Have a good rest of your